Hello everyone, welcome to my channel. Today I am going to take pharmacology topic, that is anti-epileptic drug. To make you understand about the drug part, you must know a pathophysiology of the epilepsy. So in my previous video, I have already explained the various type of epilepsy and pathophysiology of the epilepsy. If you want to see in detail, you can watch that video. I will be giving a link in the description box. Here in a brief, I will be taking what is the basic pathophysiology of the epilepsy. So in the central nervous system, there is a balance between the excitatory neuron and inhibitory neuron. This is an excitatory neuron, that is glutaminergic neuron, and GABAergic, this is an inhibitory neuron. So normally what happens, there is a balance between these two neurons, and if any imbalance happens, then that leads to the seizure. How the imbalance will happen? This glutaminergic, this is a excitatory neuron. ये आपका excitatory neuron है, this one, and this is an inhibitory neuron. So if there is increase in the excitation, अगर ये ज़्यादा हो जाता है, that leads to the seizure. And if there is a decrease in the inhibitory transmission, then what will happen? There will be again that leads to the seizure. So there is a balance between the glutaminergic neurotransmission and GABAergic neurotransmission. So how the anti-epileptic drug, what they do? They are going to either decrease this. So majority of the anti-epileptic drug, they act by decreasing this glutaminergic transmission and by facilitating this GABAergic transmission. Now how they are going to increase the glutaminergic neurotransmission? So decrease the glutaminergic neurotransmission. So either by acting on these receptor, NMDA, AMP or KNET receptor, by, you can say, decreasing the action of this glutamate on the receptor, by decreasing the release of this glutamate by acting on this sodium channel, potassium channel and a calcium channel. Then how they are going to increase the GABAergic neurotransmission? So they are going to increase the release of GABA. They are going to increase the synthesis of GABA by activating this glutamic acid decarboxylase, and they are going to decrease the reuptake by acting here. They are going to decrease the metabolism of GABA by inhibiting this enzyme. They are going to directly act on the receptor, GABA A receptor. So this is the basic mechanism of action of most of the anti-epileptic drug. So basics of pharmacotherapy of anti-epileptic drug, you can see in the next slide. So they are going to enhance GABA transmission, I have told you. They are going to diminish this glutamate transmission by acting on NMDA receptor, AMPA receptor. Then they are going to decrease this glutamate transmission by blocking the sodium and calcium channel. So they are going to inhibit this depolarization. So activation of the neuron, that is dependent on the depolarization, and depolarization indirectly, this depends upon the inward movement of the positive ion. It can be sodium, it can be calcium. So then others are, they are potassium channel opening. This also leads to hyperpolarization or decreasing the activity of the neurons. Then blocking the effect of neurotropic factor, that is collapsing response mediator protein 2. So this protein, it helps in the activation of neurotropic factor like brain derived neurotropic factor and neurotropic factor 3. So by activation of these factors, it is going to cause the axonal growth, it is going to cause the dendritic growth. So now coming to one by one, I will be taking all these drugs. So first one is this sodium channel blocker. So the drug which is going to prolong the inactivation of the sodium channel. So under that comes Phenytoin Carbamazepine, Oxcarbazepine, Esillcarbazepine, Lamotrigine, Lacosamide, Zonisamide, sodium valproate, Divalproex, Topiramate, and Rufinamide. So all these drugs, they are going to act by prolonging the inactivation of the sodium channel. So you know the sodium channel, this channel as such, it is present in three states. One is resting, then open, and then inactive. So at rest, what will happen? There is a negative ion inside, positive outside. When the channel gets open, then there is an influx of the sodium ion, and after the influx, what will happen? The channel, it go into the inactivation phase, and again for the opening or activation of the channel, it needs to come to the resting phase. Now what happens? These drugs, they are going to block this channel, and they are going at this phase, so they are going to prolong the inactivation of the sodium channel, and you have to write that they are going to prolong the inactivation of the neuronal sodium channel. So this is the one action of, and most of these drug, ये mechanism of action आपने जितनी भी इस line में drug लिखी हैं, this one point you are supposed to write in each and every drug. Plus they have additional mechanism of action like phenytoin at therapeutic dose. This is the action. But if you are going to give at high dose, it is going to act by blocking this calcium channel. It is going to cause block that. Once this is blocked, then it is going to decrease the action of this, and it is going to facilitate the action of GABA. So phenytoin, it is the major anti-epileptic drug, like a standard drug. Earlier we used to use almost in all the type of epilepsy, and it was synthesized as a barbiturate analog in 1908, and its anticonvulsant activity was tested in 1938. So mechanism of action, already I have explained how this drug it is going to act. So you can see at a therapeutic concentration, at high concentration, it is going to inhibits glutamate and facilitates GABA response and reduces the calcium influx, which already I have told. Now here important is, even at this side, the sodium channel, how the depolarization happens, there is an influx of the sodium channel, and this side also, for the release of inhibitory neurotransmitter, here also the sodium channel, they are there. Now this group of drug, are they going to block the sodium channel on the inhibitor neuron? They are going to block the sodium channel of the neuron which are firing with the high frequencies. So they are going to block the sodium channel of the excitatory neuron, and they are going to spare this one. So this is very important point here. So now there are the few important pharmacokinetic feature of this drug, phenytoin. So phenytoin, it is aqueous solubility that is very poor. So whenever you are giving by oral route, then what will happen with the oral route, it is absorption is very slow. So if you want any rapid action, तो आपको क्या करना पड़ेगा? You have to give the slow IV. Why slow IV? Even because this is the drug which can cause the damage to the intima of the vein. So once the veins they are damaged, it can cause the even thrombophlebitis, and if you are giving it by IM route, and if there is any कोई थोड़ा सा भी leakage हो जाता है, then it is, or any extravasation, that is going to cause the muscle damage. Then bound, highly bound to the plasma protein, 80 to 19%. This is going to give the drug interaction. Like if you are going to give this drug with the sodium valproate, another anti-epileptic drug, this is also highly bound to the plasma protein. So once you are going to give this with the sodium valproate, so sodium valproate, it is going to displace this phenytoin. So what will happen? If it is going to displace the phenytoin, then its level increases, and that leads to toxicity. Then it is an important enzyme inducer. It is going to induce the enzyme cytochrome 2C9 and 2C19. So by inducing enzyme, you will be seeing many important drug interactions. So it is going to induce the metabolism of oral contraceptive pills, theophylline, then doxycycline. Then being an enzyme inducer, its interaction with the other enzyme inducer like carbamazepine, another anti-epileptic drug, that is also enzyme inducer. So if you are going to give both the drug together, so they are going to induce the metabolism of each other. And if you are going to give with the phenobarbital, then again the metabolism of both will be induced. Phenobarbital, that is also going to inhibit its metabolism. So various drug interaction. In another slide, you will be seeing the different drug interaction which is seen with the phenytoin. Then another important pharmacokinetic feature, it is going to follow the mixed order kinetic. What is the mixed order kinetic? So initially, so its kinetic, it changes from the first order to zero order. So it follows non-linear kinetics. Now, because of that, now what is the first order kinetic? Here in a brief I will be telling clearance. It is dependent on rate of elimination divided by plasma concentration. So sorry, you cannot see here. I'll write it here on the top. So clearance, that is rate of elimination divided by plasma concentration. So in first order, this rate of elimination, it is directly proportional to the plasma concentration. So clearance, that is constant. So jitna elimination, that is directly proportional to the plasma concentration. But as it follows a zero order, then in zero order what happens, the rate of elimination, that becomes a constant. ये आपकी constant हो जाएगी, and then clearance is inversely proportional to the plasma concentration. Iska non-linear, iska, what is that, if you are going to give the phenytoin. So phenytoin, what will happen? Its plasma concentration, as you increase the dose, initially to theek rehti, as later on, if you are going to increase the dose, then what will happen? The plasma concentration, it is going to rise manifold. That is going to lead toxicity. And same you can see here. So initially half-life at therapeutic level, it is 12 to 24 hour. But as it follows the non-linear kinetics, first order se zero order jab gaya, now you are going to increase the dose, the plasma concentration, that will be increasing. So that is going to increase the half-life also. Because, and why it is following this non-linear kinetics? Because of the saturation of the enzyme. Then another important point in the phenytoin is never ever change the brand of the phenytoin, because the bioavailability varies. So there is a one video I have made on the bioavailability. There in detail I have explained the bioequivalence and taking the example of this phenytoin. Again, I will be giving the link in the description box for that video, so you can see in that why we don't have to, why we should not change the brand of phenytoin. Then important adverse effect with the phenytoin. So phenytoin at therapeutic level, because इसमें क्या है, therapeutic level and at higher doses. So adverse effect at therapeutic level, the most important is gum hypertrophy. So you can see here the gum hypertrophy. This is because of the overgrowth of the gingival collagen fiber. And here what is the treatment? You have to ask the patient to maintain the oral hygiene, and it is seen in more in the younger patient. You can see 20% incidence that is there. So next is hirsutism. Here you can see the coarsening of the facial feature, hirsutism and acne, that is also very common with the phenytoin. Then hypersensitivity reaction. So though it is rare, like rashes, discoid lupus erythematosus, lymphadenopathy, neutropenia, but whenever it happens, we have to ask the patient not to take the drug. You have to discontinue the drug. Then it is going to interfere with the activation of vitamin D metabolism and calcium absorption and metabolism. So that leads to osteomalacia and even rickets. Then also inhibit the absorption of the folic acid, so can lead to megaloblastic anemia. It inhibits the insulin release, so hyperglycemia. Then if used during pregnancy, it is called the fetal, it is going to cause a fetal Phenytoin syndrome. That is because of the metabolite, arneoxide metabolite. Now what will happen in the fetal Phenytoin syndrome? You can remember it in a PCM, that is hypoplastic phalanges. इसमें आएगा आपका हाइपोप्लास्टिक, हाथ के जो होते हैं आपके phalanges. Then cleft palate, and you can write the hair lip or hair lip, and microcephaly. ठीक है. So these are the adverse effect of the phenytoin at therapeutic level. Now if you are going to give it at a higher dose or a toxic dose, so mainly it is going to produce a cerebellar and vestibular manifestation. Cerebellar जब भी होता है, there will be ataxia, vertigo, nystagmus, diplopia and hallucination, plus drowsiness, behavioral alteration, mental confusion, disorientation and rigidity, and epigastric pain, nausea and vomiting. With IV injection, already I have told, this is going to produce and also fall in blood pressure and a cardiac arrhythmia. Now, where we are going to use? So earlier it was a standard drug for almost all tonic-clonic and all the types of tonic-clonic and a partial seizure. But nowadays we do not prefer this drug, because why it is not preferred? Number one, because of its adverse effect, the most important. Its adverse effect, and most important है, आप हम इसको orally है, oral because of the less aqueous solubility it is not absorbed. IV अगर हम देते हैं तो it is going to cause the damage. IM हम दे नहीं सकते, उसमें भी it is going to cause the damage. Then important drug interaction. There are many drug interaction that is seen because it is highly bound to plasma protein. It is enzyme inducer. And the another one is it follows the non-linear kinetics from the first order to zero order. So we have to maintain its plasma concentration. That is also difficult. So nowadays, कब हमें use करनी है? When other available drug, if we cannot give those to the patient, then only we are going to put the patient on phenytoin. And आपकी बाकी रही status epilepticus, here also we give a pro-drug for phenytoin that is completely replace this phenytoin, because we can give it, and another here is we cannot give it with the glucose because it gets precipitated. So phosphenytoin, it has completely replaced the phenytoin because it is a water soluble. Use another color. It is a water soluble. एक तो आपका ये हो गया, water solubility इसकी अच्छी है, so we can give it by IV IM route. ठीक है. Then इसके आपके drug interaction कम है, kinetics भी इसकी ठीक है, we can give it with the glucose, it does not get precipitated. So in status epilepticus, if phosphenytoin, if it is not available, then only we are putting the patient on a phenytoin. Then for the trigeminal neuralgia, the drug of choice is carbamazepine. That is the drug of choice. And the second one, then we can give phenytoin, baclofen, and अगर जो non-responder है उनमें फिर हमने ये वाली देनी है. Then it is a drug of choice for the digitalis induced arrhythmia. Now, what is the important drug interaction? So many I have told earlier also, because it is an enzyme inducer. So it is going to induce the metabolism of oral contraceptive, theophylline and doxycycline. And carbamazepine, this is also a inducer. So they are going to induce the metabolism of each other. Then another important is like then it is going to phenobarbital. Phenobarbital का भी same है. Phenobarbital and phenytoin, they are going to induce the metabolism of each other. And phenobarbital, it also inhibit the phenytoin. So बड़ा जो भी है, whatever the level, it does not change. एक तरह वो बढ़ाता भी है और कम भी करता है. Then it is going to, अब क्या है, अब ये हो गया inducer. Now where it is going to inhibit? It is going to inhibit the वारफ्रिन मेटाबॉलिज्म. एक इसको कम करता है, वारफ्रिन का लेवल को, एंड देन सुक्राल्फेट इसके लेवल को कम करता है बाय बाइंडिंग विद द इन द जीआईटी. सो इट इज गोइंग टू डिक्रीज इट्स एब्जॉर्प्शन. देन बिकॉज ये एंजाइम इंड्यूसर है, सो विद द एंजाइम इनिबिटर लाइक साइमेटिडीन हो गया आपका, विद द साइमेटिडीन, क्लोरमफेनिकोल, isoniazide and warfarin, they are also going to inhibit its metabolism. Valproate का मैंने पहले बता दिया because this is also bound to the plasma protein, so they are going to displace it. So now the second drug of this group is, so phosphenytoin already I have told. So next is carbamazepine. Carbamazepine, here another the second drug which is also going to act in the same way like a phenytoin. It is going to prolong the inactivation of the sodium channel by binding the सोडियम चैनल. व्हाट आर द अदर एडिशनल, जैसे फेनिटोइन में एडिशनल था, ये कैल्शियम को भी कर रहा है, यहाँ पे भी एक्ट कर रहा है, यहाँ पे भी ये एक्ट कर रहा है, इधर गाबा वाले पे भी एक्ट कर रहा है. इसी तरह कार्बामेज़ेपिन, इट्स एक्शन इज जस्ट लाइक अ लिथियम. इसके एक्शन और कौन से, लिथियम लाइक इफेक्ट. So it is used in mania, mood stabilizing drug, and bipolar disorder. So in a mania and bipolar disorder, you will be seeing apart from the lithium, rather lithium हम नहीं use करते because of its safety margin. वो आता है safety margin, it is very very less with the lithium. So ज़्यादातर anti-epileptic drug they very commonly used for the treatment of mania, because efficacy of carbamazepine, efficacy of sodium valproate, they are almost equal to lithium, and definitely side effect they are less. Then another important action of the carbamazepine, antidiuretic. It is going to enhance the ADH action on the renal tubule. Now here again with the phenytoin, few of the important pharmacokinetic. यहाँ पे सबसे important kinetics क्या है, pharmacokinetic effect यहाँ पे सबसे important है, it is metabolized by oxidation, then hydroxylation and conjugation. ये तीन है, oxidation, hydroxylation and conjugation. But with the oxidation, it is going to form an active metabolite, that is 10-11. ये वाला इसका बन रहा है epoxy carbamazepine. This is responsible for the various adverse effect. So this is which is not formed in the oxcarbazepine and Esillcarbazepine. So इन दोनों में आपका जो ऑक्सीडेशन वाला पार्ट है, दैट इज दिस इज द डिफरेंस बिटवीन दिस वन टू द कार्बामेज़ेपिन. अदरवाइज ऑक्सकार्बाजेपिन, दिस इज अ प्रो ड्रग ऑफ द और कॉन्जेनर ऑफ कार्बामेज़ेपिन. एज सून एज यू गिव इट, दिस इज ऑल्सो कन्वर्टेड इनटू द कार्बाजेपिन, एंड दिस इज अ enantiomer, Esillcarbazepine, but this is also converted into the carbazepine. So both they do not have this side effect. So here what happens, this they are not converted into the active metabolite. So oxidation उसमें नहीं होती, सीधी conjugation है, hydroxylation ये वाला नहीं बनता, तो side effect they are not seen. So it is a substrate as well as inducer. मतलब इसका क्या मतलब है, it is a substrate as well as an inducer. So auto induction, this means the auto induction that is very common with this. अगर मैं बोलती हूँ ऑटो इंडक्शन इसके साथ बड़ी कॉमन है. सो व्हाट विल हैपन इफ यू आर गोइंग टू गिव दिस ड्रग. सो इनिशियली यू स्टार्ट विद द लो डोज, आप इसको कम डोज देते हो. जब आप फिर धीरे धीरे क्या होता है, बिकॉज इट इज गोइंग टू कॉज द मेटाबॉलिज्म ऑफ इट्स ओन, it is causing the metabolism of its own. So what will happen, slowly you have to increase the dose क्योंकि अब metabolism इसकी खुद की हो रही है, so level will increase. So what will happen, so half life 20 to 40 hours, but it is going to decrease to 10 to 20 hours on chronic medication because of the auto induction. Now what are the important uses, this is a drug of choice for the complex partial seizure and the trigeminal neuralgia. We can use in other also like grand mal epilepsy, simple partial seizure. So in trigeminal neuralgia, carbamazepine, जब भी MCQ आए, carbamazepine, that is a drug of choice for the trigeminal neuralgia. What alternative we have? We can use phenytoin, we can use lamotrigine, we can use baclofen, they are the alternative. And अगर patient फिर भी respond नहीं कर रहा, फिर उसको gabapentin. आज की डेट में कई बार सीधे clinician they put the patient on the gabapentin. Now what are the adverse effects? I told you adverse effect. Most of the adverse effect they are because of the epoxy carbamazepine metabolites, which is not seen with that. So those neurotoxicity like sedation, dizziness, vertigo, diplopia, and ataxia. Higher doses पे vomiting, diarrhea, worsening of the seizure, and if the patient is acutely intoxicated, the patient can go for coma, conversion, and cardiovascular collapse can happen. Then allergic reaction like rash, photosensitivity. So इसमें जितने भी एंटी एपिलेप्टिक ड्रग है, you just see एक आपके अगर मोटे मोटे एक CNS से रिलेटेड है, एक एलर्जी से रिलेटेड है, एंड एक आपके टेराटोजेनिसिटी. ये तीन पॉइंट्स आप जब भी एंटी एपिलेप्टिक पढ़ो, इसके साइड इफेक्ट ये तीन जस्ट लुक फॉर दैट. ठीक है, ए ग्रैनुलोसाइटोसिस, ल्यूकोपीनिया, ए प्लास्टिक एनीमिया. Then because it enhances the ADH action, so water intoxication and hyponatremia. So water intoxication and hyponatremia, this is more with the आपका oxcarbazepine उसके साथ है. इसमें एक और साइड इफेक्ट hepatotoxicity which is not seen with the oxcarbazepine. Then fetal malformation. Fetal malformation ऐसे तो carbazepine के साथ, carbamazepine के साथ तो नहीं है, but if you are going to give this one in combination with the sodium valproate, then fetal malformation can happen. So another one is Oxcarbazepine and Esillcarbazepine. Already I have told you the difference between this one with the carbamazepine. Otherwise, mechanism of action and rest of the things, they are same. Now next group of drug is, that is lamotrigine. Now how does lamotrigine it is going to act? So lamotrigine, one mechanism of action, it is also going to prolong the inactivation of the sodium channel. एक चीज और याद रखनी, this is a, they are the few anti-epileptic drug which comes under the broad spectrum category. This is also comes under the broad spectrum. तो एक तो ये prolong तो करता है. Second one is it is going to directly, इसको directly inhibit कर देता है sodium channel को. So by inhibiting this directly, it is going to you can say it is going to maintain that it is going to stabilize the membrane. This one, presynaptic membrane, it is going to cause a stabilization, so especially of the excitatory neurons. So less release of not only glutamate but aspartate, उसकी भी कम होती है, दोनों की दोनों. So this is the thing which is going to make it a broad spectrum. So you can see it is going to prolong this, directly block the voltage sensitive sodium channel. It is going to inhibit the glutamate release. Half life is 24 hours. It is very well tolerated, this lamotrigine. So the only side effect which very commonly is seen here is a rash. So typical hypersensitivity reaction agar ye aata hai, this is a typical hypersensitivity that is seen with the lamotrigine. This is important MCQ, and where we are going to use, mostly it is used because broad spectrum. तो जितने भी आपके seizures type हैं, we can use it in everywhere, can use it as a monotherapy and can use it as an add-on therapy. Next is Lacosamide. Now Lacosamide is another next drug. This also the same mechanism of action. Another thing is, in the neuron, I told you there is collapsin response mediator protein 2. This is there. Now what is its action? They are going to promote the dendritic and axonal growth by activating the neurotropic factor, that is brain derived neurotropic factor and neurotropin factor 3. Now this lacosamide वो ये वाला तो करता ही है prolongation, plus this is also going to act here. ठीक है, तो ये यहाँ पे भी काम करता है. So what will happen, by it is going to block this. So what will happen? So it is going to stop the effect of neurotropic factor, that is brain derived neurotropic factor and neurotropin factor 3. So there will be no growth. So this is also as an add-on therapy. So this is a newer drug. Lacosamide होगी आपकी, उसके बाद ये अगली Zonisamide होगी, ठीक है, and Topiramate होगी आपकी. ये all these are Topiramate, these are the newer drug that comes under this. Then comes Zonisamide. Zonisamide, here also the same action, it is going to prolong that. So Zonisamide, another important thing, एक आप यहाँ पे देख रहे हो ना calcium, this is a high voltage gated calcium channel. So there is another type of the calcium channel which we see in the thalamus cortical neuron. So what happens here, we see the T type of calcium channel, transient or slow entry of the calcium that happens in the thalamic neuron. And certain drug, they act by blocking this T type of calcium channel. One of the drug, that is Zonisamide, that is there. So sulfonamide derivative ये हो गया, it also inhibits the T type of calcium current. So in my previous video, I have explained the significance of this T type of calcium channel. So what happens in the absence seizure? In the absence seizure, if you see the EEG, they show a characteristics 3 Hz synchronous 3 Hz spike and wave pattern, or wave and spike pattern you can say. And this synchronous 3 Hz spike and wave pattern in the EEG, this happens because of the, there is a, you can say, and a cortex. cortical neuron. Now this thalamic neuron and a cortical neuron, there is a reciprocal oscillation and activation between this thalamic and cortical neuron that leads to this synchronous 3 Hz spike and wave pattern. And the thalamic neuron, there are the T type of the calcium channel, and from that calcium enters, which leads to this absence seizure. So for the treatment of absence seizure, we have to give the drug which act by blocking this T type of calcium channel. So one of the drug, that is a Zonisamide. So other two drugs, they are the sodium valproate and then ethosuximide. So this is a, we use it as a add-on drug in the partial seizure, in the absence seizure, then grand mal, epilepsy, and in infantile spasm. So important adverse effect: drowsiness, we have a cognitive impairment, rashes, and renal stone, they are seen with this. Next important drug is valproic acid. So this also comes like lamotrigine. I have told it's a broad spectrum. So this is also a broad spectrum anti-epileptic drug, valproate. So you can see with the purple color, everywhere I have drawn with the purple. So you can see at a different site it is acting. अभी एक इसमें मिसिंग है, एक कौन सा मिसिंग है? इट ऑल्सो एक्ट बाय ब्लॉकिंग दैट टी टाइप ऑफ, यहाँ पे भी ये काम करता है, टी टाइप ऑफ कैल्शियम चैनल. यहाँ पे भी आपका सोडियम वैल्प्रोएट विच इज मिसिंग, थैलेमिक न्यूरॉन पे जो आपका टी टाइप ऑफ कैल्शियम चैनल है, सो इट इज गोइंग टू एक्ट ओवर देयर. सो एक वो हो गया. देन अनदर वन इज 2, 3, 4, 5 at a 5 side. So it is going to prolong the inactivation of the sodium channel. एक तो इसका ये हो गया सोडियम वैल्प्रोएट का, मतलब it is going to decrease the activation of the glutaminergic neuron and facilitate the activation of the GABAergic neuron. Now how it is going to inhibit this glutaminergic? By prolonging the inactivation of the sodium channel. It is going to act on NMDA receptor. It is going to block its action on NMDA receptor. ठीक है. फिर उसके बाद इसका T type of calcium channel on the thalamic neuron, it is going to act over there. Now how it is going to increase the GABAergic transmission? By increasing its synthesis. ये glutamic acid decarboxylase, it helps in the synthesis. This enzyme, it participate in the synthesis of GABA. You can see from the glutamate to the gamma aminobenzoic acid, this is the enzyme glutamic acid decarboxylase. So it is going to activate this glutamic acid decarboxylase. So it promotes the synthesis of GABA. So once this GABA, it is released, then there is a reuptake by the transporter, and within the neuron again it is metabolized by the transaminase, GABA transaminase. So this valproate, it is going to inhibit this GABA transaminase. So it is going to, you can see now, so it prolongs the inactivation of the sodium channel, inhibits the calcium mediated T current, blocks NMDA receptor. ये आपके आगे excitatory, inhibitory में it is going to facilitate GABA by inhibiting its degradation, ठीक है, and by increasing its synthesis by all this, ठीक है. So it is again pharmacokinetic. अभी तक आपने inducer पढ़े. This is a inhibitor. So valproate, I already, so valproate, it is going to displace the phenytoin and lamotrigine के अगर साथ देते हो, so it is going to inhibit the metabolism of lamotrigine. So आपने जब भी इसको इसके साथ देना, तो you have to decrease the dose of the lamotrigine. So where we are going to use, this is a drug of choice for the absence seizure. I will tell you. So when we cannot give this because of the, so if the child age is below 3 years, तब नहीं हम देते, and which is very uncommon. Absence seizure, it is not very common in the children below 3 years. It is first line drug for the grand mal, epilepsy, partial seizure, myoclonic, atonic, and Lennox-Gastaut syndrome. So all these classification of the seizure I have told in my first lecture. You can go and watch that video. So things will be more clear about the different type of the seizures and what are their important clinical features. So why we cannot give it below the 3 years? Because of its important, these are the anti-epileptic. So because of its important side effect, that is a liver damage. it causes the fulminant hepatitis. स्पेशली इन द चिल्ड्रन बिलो 3 ईयर. तो अगर किसी भी बच्चे को एब्सेंस सीजर हुआ, usually for this is a drug of choice for the absence seizure, but if the child age is below 3 year, then the drug of choice for this becomes what is ethosuximide. तब आपकी ethosuximide, that is the drug of choice. Otherwise आप absence, so there are the total 3 drugs which act by blocking the T current. One is ये आपकी valproic acid, second one is ethosuximide, and the third one is Zonisamide. So what are the non-epileptic uses? Mania, bipolar disorder, panic attack, migraine prophylaxis, and tardive dyskinesia. So you can remember the adverse effect of valproate by its spelling. V stands for vomiting, A for the alopecia and curling of the hair, L for the liver damage, there will be fulminant hepatitis, P for the pancreatitis and PCOD, R for the rash, O for the obesity which leads to weight gain, A for the agranulocytosis, and there are the fine tremors, E for the epigastric pain. So what are the important, I have already discussed adverse effect. Then another important is a Divalproex. You know what is a Divalproex? It is a combination of 1:1 ratio of sodium valproate and valproic acid. दोनों के दोनों इसमें combine किए होते हैं. इसको mostly seizures में नहीं यूज़ करते, लेकिन जहाँ पे mania है, bipolar disorder है, वहाँ पे इसको हम इसके side effect they are less as compared to the valproate. Otherwise mechanism of action, rest of the things they are same. Now the next drug of this group, that is a Topiramate. Now how the Topiramate it is going to act? So here again you can see with the this डिफरेंट कलर टॉपिरामेट यहाँ पे और यहाँ पे. सो यहाँ पे तो सेम है इसका मैकेनिज्म ऑफ एक्शन. यहाँ पे ये केनेट रिसेप्टर यहाँ पे काम करेगी, और यहाँ पे क्या है, इट इज़ गोइंग टू एक्ट ऑन द गाबा ए रिसेप्टर. तो गाबा नर्जिंग, गाबा फैसिलिटेटरी एक्शन इसका टॉपिरामेट का है. सो यू कैन सी प्रोलॉन्ग इनहिबिट द केनेट रिसेप्टर, प्रोलॉन्ग्स पहला सेम inactivation of the voltage dependent sodium channel, inhibits the kainate receptor, then activates the GABA A receptor, and it is going to cause the neuronal hyperpolarization to the potassium channel. So we can use it as an add-on drug in the refractory, जहाँ पे फर्क नहीं पड़ रहा पेशेंट को, with the traditional partial seizure, grand mal epilepsy, then Lennox-Gastaut syndrome, absence seizure, myoclonic, and in the prophylaxis of the migraine. So these are the adverse effect of the topiramate, like patient will have a sedation, ataxia, impairment of attention, there may be amnesia, weight loss, paresthesia, and nephrolithiasis. Now the last drug of this group, this is the newer one, that is a Rufinamide. So इसमें बेटा ज़्यादा तो नहीं है. This is approved for the mainly for the Lennox-Gastaut syndrome. So it is also act by prolonging the inactivation of the sodium channel. So one group of the anti-epileptic drug which mainly act by prolonging the inactivation of the sodium channel, that I have covered in today's lecture. So in the rest of the drug I will be taking in my next video. So far, what are important questions which you must know or which can be asked in the exam? Very commonly, the question which is asked, classification of anti-epileptic drug. So far, it is not complete. I have covered only one part. Then mechanism of action, therapeutic. This is very important. Mechanism of action, therapeutic uses of these two drugs. This I have covered, Phenytoin, and usually these two drugs, they are mainly asked for the mechanism of action, therapeutic uses, and adverse effect. Then adverse effect of Phenytoin, ये अलग से क्वेश्चन आ जाता है. Then why Phenytoin? They has replaced the Phenytoin. Newer anti-epileptic, here also I have told few of the newer anti-epileptic. So you can include here under this category Lamotrigine, Lacosamide, Zonisamide, then Divalproex, and Rufinamide, Topiramate. So there are many more. They are there still. I have to discuss. That will be discussing in my next video. What are the key points so far? Non-linear kinetics, that is followed by which anti-epileptic drug? Yes, it is by the Phenytoin. Now bioavailability of the different market preparation of the Phenytoin, it may differ. ये भी आपको याद रखना है, इसलिए कभी भी इसका ब्रांड नहीं चेंज करना. Third thing is Phenytoin, it is not used in absence seizure and myoclonic seizure because it is going to aggravate. Drug of choice for the trigeminal neuralgia, yes, right, it is a carbamazepine. Oxcarbazepine. This is the drug of choice. So if you like my video, kindly subscribe my channel and put up your important suggestion in the comment box. See you in my next video.